I think all of us see pediatric cataracts in our clinic, and we know that not everybody should venture into pediatric cataract surgery without being a very good anterior segment cataract surgeon first, because these are difficult cataracts. The nucleus is not difficult, but everything else is difficult. And if you have, the slides are not advancing. If the things don't turn out the way you have planned, then you can have disastrous consequences. Okay? Yeah, so there are several considerations. First is whether it's a unilateral versus a bilateral cataract, because that will have implications on when you're going to operate. If it's a bilaterally symmetric cataract, you can buy some time before you intervene, but if it's a unilateral cataract, you know it's going to be at risk for amblyopia, so you want to intervene as soon as possible. Again, the decision regarding IOL placement, if the fellow eye is phakic, then you want to try and make this cataractus eye pseudophakic rather than aphakic. Which lens to use, whether to do undercorrection. Again, in a bilateral cataract, it may be okay to, it would probably be advisable to undercorrect. But if it's a unilateral cataract, then you don't want to make the cataractus eye too hyperopic, because that again is amblyogenic, so that's debatable. And again, if it's a unilateral cataract, sometimes you may not need to do systemic investigations. It could just be an idiopathic this thing. But if it's bilateral, then it would be recommended that you send to a pediatrician to investigate for the cause. One of the important considerations in any pediatric surgery, not just cataract, is the GA considerations, especially when you're going to be operating two eyes of a child. Whether one should be administering GA twice, or should one do sequential bilateral surgery under the same general anesthesia. So there are two schools of thought, but there has been a lot of talk lately that it may make sense to actually do both surgeries in the same setting, one after the other. Of course, you make sure everything is different, including the batch of intraocular solution that you use and a completely new trolley, etc. Which anesthesia to use? Again, I think all of us are using different agents. In our practice, predominantly we use a laryngeal mask, but sometimes we even operate under ketamine. But we have to be mindful of the effect of that on the intraocular pressure. By and large, because cataract surgery is not very long, laryngeal mask does work, but if you think it's going to take longer time, better to do an endotracheal intubation. There are various surgical considerations, where to make the incision, how large should it be, should one suture it. Anterior capsulotomy is different from an adult eye. We know that these capsules are elastic and the rhexis tends to run. Many of these children require posterior capsulotomy, especially if they are under 8 years of age. I like to do a primary posterior capsulotomy along with an anterior vitrectomy. Otherwise, we know that they have 100% PCO. Beyond 8, you can YAG it, so that it may not be that necessary. And of course, when to put the lens. In my practice, I put an intraocular lens if the child is older than 1 year, but there are several of us who are using IOLs even for younger children. It's important that you use a high density viscoelastic, not just HPMC, because HPMC tends to come out of the paracentesis very soon, so it will be recommended that you use sodium hyaluronate or some dense viscoelastic of a higher concentration, so that it keeps the anterior chamber formed at all times and keeps the capsule flattened. Basically, if the capsule is flattened, there will be a lesser chance of your rhexis running out. The anterior capsulotomy is best done with a microrhexis forceps rather than with a needle, because with the needle sometimes it tends to run out and you will need the pull to be centripetal, which is sometimes difficult to do with a needle. So if you have a forceps, whether you use a microforceps like this, or you could even use a utrata through a main wound, the force is centripetal, as you can see here, and also slightly anterior towards the center of the cornea. And if you use this kind of a force, usually you're able to control the size of the rhexis. So you can see, even though you're pulling centripetally, it ends up becoming fairly large. You have to, of course, like in any forceps rhexis, you have to multiple times you have to regrasp. And because you're using a high density viscoelastic, there's very little escape of the OVD, and the anterior chamber remains stable. So everything is a lot more controlled. Sizing, ideally the anterior CC should be just short of the size of your optic, of your intraocular lens which you're planning to use. Other than this, you could also use a vitrector. A lot of people use a vitrectomy machine to make the anterior capsulotomy. That's perfectly fine, but you have to ensure that you have a form bag and you don't lose the rhexis. Posterior capsulotomy is another thing that we need to use in many of these patients, and the size of this should of course be smaller than your anterior capsulotomy. You don't want the lens falling in through that, so it should be large enough to allow light to pass into the eye and should be well centered. But if it's too large, then sometimes you may have problems of placing the lens. Some people like to do the posterior capsulotomy after putting the intraocular lens by using a vitrectomy. I like to make a primary capsulotomy in this manner. So make a little nick in the posterior capsule, as you can see here. You can use a needle for that. Put some viscoelastic to push the anterior vitreous face back, and then you grasp the capsule with a microrhexis forceps, and again using a centripetal and anterior force, you make a posterior capsulotomy. The posterior capsulotomy is actually a lot easier than an anterior capsulotomy because it's smaller, and essentially all your force is kind of directed centripetally. So very rare that you will actually end up losing a posterior capsulotomy. You may disturb the vitreous, but most of the time you are able to complete that circle. And like I said, some people like to do it afterwards. You can use a vitrector to do it after putting the lens. You can go around the IOL and do it. You could even go past plana and make the opening in the posterior capsule. All are fairly okay, and it doesn't really matter as long as you get an intact posterior capsulotomy. Lately, I have the Zepto, and I've been using the Zepto to make capsulotomies, and I found that this is a very useful instrument because you get a perfect round rhexis of a proper size, which sometimes is difficult to do in a pediatric eye. So the anterior capsulotomy comes out really good. I like to use a high density viscoelastic when I'm doing a Zepto in pediatric eyes. So this basically is a device which catches onto the anterior capsule with using a suction cup, and this has this metallic ring called a nitinol ring, which delivers a shock of current, which basically makes a hole in your anterior capsule, and you can see you get a perfect round rhexis like that. It has these little fibers attached to the border, which are basically coagulated protein from the collagen from the capsule. And then, of course, the rest of the surgery is as usual. The posterior capsulotomy currently you have to still do manually, but it is under development, a handpiece for that using the Zepto, so that should be interesting. So again, just showing that how putting the viscoelastic there pushes the vitreous back, and I find this a very useful thing when you're doing the posterior capsulotomy. And a good red glow, of course, makes visibility of that posterior capsule very, very easy. And you can see a well-centered round posterior capsulotomy that of course will result in a good outcome. So the Zepto is now coming with this kind of a handpiece which can go into the bag. It's a smaller sized handpiece which can give you a smaller PCCC. Of course, we'll have to see how clumsy or easy it is to do to introduce this into the bag and do it without causing too much damage to the zonules. So you can see that's the edge of your Zeptorhexis, perfectly round, and you could use a femto, but then you would have to give the child would be under GA. So how would you shift him from the femto table to the operating table unless you have got a Zima machine? Anterior vitrectomy is something I do in every case where I do a posterior capsulotomy, and I think it's an important step because otherwise the antivitreous face works like a scaffold for the posterior capsular opacification, and all the lens epithelial cells grow on that and form a sheet. So you can use diluted triamcinolone to stain the vitreous if you like, otherwise you can just directly go ahead and do the vitrectomy. The principles of vitrectomy are the same as in any other surgery. Higher cut rate than vacuum, and make sure that you clear the entire posterior capsule of any vitreous. So you'll have to go behind and direct the port upward and kind of complete your anti-vitrectomy. Pars plana vitrectomy is also a reasonable option, and many people prefer to do that. You could use the smaller gauge vitrectomy cutters now, which are available now, 23, 25, etc. So you can also, like I said, go after putting the lens around the IOL and do it. Both are okay, but sometimes in this it may be a little uncontrolled, and you may risk having a larger or an extension of your posterior capsulotomy, which is not desirable. Of course, if you're not putting a lens, then through your side port itself you can go ahead and do the vitrectomy, and even the posterior capsulotomy can be done with the cutter itself, which is fairly okay. Which lens to use is again something one has to think about. Single piece lenses are okay, but PMMA lenses, if they're very large, they can press on the angle and cause glaucoma. So you want to use a single piece hydrophobic lens. 3-piece lenses again are a very good choice, especially if you're not sure whether you'll be able to get a perfect posterior capsulotomy. You can put them in the sulcus and then capture the optic behind the rhexis, and that works really well. I'll just go through these. So acrylic material is preferable over PMMA, and hydrophobic material is preferable over hydrophilic, and those are results of an APOS survey which was conducted in September 2007. Predominantly, people prefer hydrophobic lenses, as you can see, both for bag and sulcus placement. Toric IOLs is a bit controversial. We know that the pediatric cornea keeps changing its shape till much later. So unless the astigmatism is very high and you just want to kind of reduce it, I would not recommend using toric IOLs in pediatric eyes. There are other newer lenses like the bag in the lens, which has been popularized by Mary Tessianon, and you have these light adjustable IOLs whose power can be adjusted after surgery, which may be useful, but unfortunately they're not available in India. I'd like to just close with this important point. All pediatric cataracts, we must suture the wound, even if they're perfectly sealed on table, because these children tend to rub their eyes, they have injuries, and you really will regret it if you don't put a suture sometimes. So even though it means that you might have to go back under anesthesia to take out the suture, it's worth it. Always suture not just your main wound, even your side ports in pediatric cataracts. And don't forget the aftercare. The surgery is not the end of the management. There's a long journey after that. Amblyopia needs to be managed. These patients often go on to develop high myopia. Possibly dilute atropine, which is being used for control of myopia, may have a role here to reduce the myopic shift that they have. Visual rehabilitation using the appropriate contact lenses or glasses, monitoring the intraocular pressure, EUAs periodically, and suture removal at appropriate time is important.